and why we use them in ACLS. As I mentioned earlier, you'll need to know the appropriate time to administer a drug, the dose, and if you can rebolus it, how many times and how much. So they're all listed on that algorithm sheet that I provided you before. The two people that are going to be helping me on Friday will be Dr. Catherine Klump. She's an MD, PhD. She's finishing her, she's chief resident in family medicine over at OU, a friend of mine for a long time. The other is Dr. Dan O'Donoghue, who's known for longer than you've been alive. So he's going to come over here. We're going to be in 3 stations. We'll go through some of the, we'll split these conditions up and we'll go over them. You'll practice doing what's called a mega code, and then we'll give you a written test and you'll be out of here. It's scheduled from 1 to 5. It probably won't take till 5 o'clock. It depends on how prepared you are. If you don't pass it, you get to go through it again. So you won't leave here Friday afternoon until you do pass it. So preparation is the key. Any questions? So what we'll do is we'll go through this short presentation, and then I'm going to show you several things. One of them is when I say a mega code, what does that mean in terms of ACLS testing? And I'll show you, I'll go through one with you, and how you should respond. Anybody here taken ACLS before? Just one person? Okay. All right, so we'll go through it. Maybe Kendall can help me when we do it. And then I have a lot of things up here that I want to cover, because on December 5th, 6th, and 7th, whatever that Wednesday, Thursday, Friday is, we're going to have cadavers up here. You're going to be doing a lot of airway and skills on these cadavers. And I want you to have a feeling for these things before you go in there. Otherwise, you'll spend too much time waste time trying to figure out which hand to hold a laryngoscope in. I want you to know that. So I'm going to leave that here. So I want you to be able to intubate it. As we'll put it back there on the back row. And just so over lunch or whenever over the next week, drop a few tubes, and then we'll go through some of these other toys here. Okay? So first of all, ACLS pharmacology. You need to know that the drugs, the indications, and the dosages, and the objective of using these drugs, there are several. One is to aid in resuscitation. Thanks.
This is all of them.
Oh.
Yeah,
Oh.
that's all of them.
Good.
Yes.
By aiding in resuscitation, some of the drugs, and I'll go into it a little bit later on, makes the heart more susceptible to shock. So it gives you an advantage in resuscitation. Others are to prevent or treat arrhythmias. We were just talking about procainamide, amiodarone, lidocaine. These drugs, what they do is they delay conduction, or they do something related to conduction, usually through ion channels that cause the heart to reset itself. So others, when you convert somebody out of ventricular fibrillation, you don't want them to go back into ventricular fibrillation. So there's a way you can stabilize the heart to keep it from going back. And finally, to relieve pain and anxiety, especially when you're talking about myocardial infarction. That's what we're talking about there. First drug is oxygen. Oxygen is, if you're having ischemia, you would think that oxygen is the best thing in the world for it. So, as I mentioned to you before, putting on a non-rebreather mask hooked up to the wall oxygen so that you're breathing 10 to 15 liters is the way to go, and not the nasal prongs. Remember, the limitation of the nasal prongs, just not enough. And if you increase nasal prongs up to 6 liters a minute, which is the max, It's like if I was standing underneath your nose and blowing as hard as I could up into your nose. It's rather uncomfortable. If you are in cardiac arrest, if you're not breathing, then you need to breathe them. A mask with oxygen flowing from the wall is not going to do it. So you need positive pressure. Positive pressure can come in the way of a BVM, bag valve mask. Have I talked about this before? A bag, a one-way valve, and a mask, right? The way this is used is, and I'm not sure what I have told you, what I haven't told you, so if I've been over this, just let me know. The dumbass mnemonic from the Heart Association is C and E. Put your fingers in a C around the hub here. Did I do this before? Over the nose and mouth, put the E underneath their mandible. If they have a stable C-spine, elevate their head, compress the bag over 1 second. Just as you see the chest start to rise, and then stop. Don't do this, okay? So it's nice, easy respirations. So the cycles that you're going to be doing are 30 to 2, 30 to 2, 30 to 2. So 30 chest compressions, 1, 2, and then back on the chest compressions, okay? You use a BVM with an OPA. This is an oropharyngeal airway. They come in a ton of different sizes. Here you got the little newborn one right there, okay? So the way these, what this is, the purpose of this thing is to keep the tongue off of the back of the throat. So the way you do it, you put it in upside down. And then as you lower it, now you can't have a gag reflex with this, obviously. As you lower it, you rotate it 180 degrees, and that traps the tongue right here. That traps the tongue, let's see. That traps the tongue and keeps it off the back of the throat. It also has these grooves in it that allow air to go down through there, okay? And put it in until this thing is at your lips. Now the proper sizing of this is from the angle of the mouth to the angle of the jaw. That's the proper sizing. When you're trying to figure out how big do I need to use, okay? So a BVM with an OPA, you're in good shape. This thing right here is called a laryngeal mask airway. It comes in little pediatric sizes as well. The way you insert it, so an endotracheal tube is meant to go through the vocal folds. It's meant to go in the trachea. This thing sits on top of the larynx. It doesn't go through the folds. So what you do is you put a little KY jelly on it. You put it in upside down as well, and you just lower it down. And as you lower it down, you rotate it 180 degrees and just push it in until it stops. You just push it until it stops. It won't, the point will go down in the esophagus, and the top will sit on the larynx. Right? And then you inflate the cup of this thing with air. And that seals it inside the oropharynx. Okay? An LMA and an endotracheal tube are called definitive airways. If you have a definitive airway in place, if you'll notice on the guidelines there for ACLS, you don't do 30 to 2, 32. If you have a definitive airway in place, you do continuous chest compressions and continuous bagging every 6 to 8 seconds. Okay? And you don't need to time the bagging with the compression if you have a definitive airway in place. Okay? This is also, if you, just in case you, this is also called a vagina on a stick. So you might hear it referred to as that. Okay. We'll go over endotracheal tubes here in just a minute. Okay. Epinephrine is the first drug. The dose of epinephrine is 1 milligram. You can repeat it every 3 to 5 minutes. There's no maximum dose. Every 3 to 5 minutes. So if somebody's during a code, you have somebody recording. So they, you tell me, let me know when every 3 minutes is up, and you can give another dose of epinephrine. There's no max dose. There's no change in the dose. It's 1 milligram. Now, most of these drugs come in pre-filled ampules. So in a crash cart, you just pull it out, you grab the amp of epinephrine, it's already pre-measured at 1 milligram. There's 10 cc's in there. The dilution is 1 to 10,000. If you do your Jethro Bodine goes into math and carry to naught, 10 cc's at 1 to 10,000 equals 1 milligram. So you just slam that 1 milligram of epinephrine. You push it in nice and fast, okay? And then follow it with a flush. All of these drugs, you follow it with a flush, okay? The indications for epinephrine are VFib, pulseless ventricular tachycardia, PEA, and asystole. The mechanism of action of epinephrine, well, you know what it is. It's an alpha and beta agonist, it's sympathomimetic. Right? Epinephrine increases myocardial oxygen demand. It's going to jack up the heart rate. So if you got a heart that was fibrillating and you converted them with epinephrine, you got a back. They have an ROSC, return of spontaneous circulation. But their rate is too slow. You don't want to give them epinephrine because of how much it increases myocardial oxygen demand. There are other options that we'll talk about later. Okay? Increases the automaticity of the heart. So in other words, bottom line is you don't give epinephrine to a pissed off heart. If you just remember that, you won't ever make a mistake in it. If you cannot establish vascular access, which is unheard of these days because of intraosseous needles, you can shoot epinephrine down the endotracheal tube. There are the mnemonic for things going down the endotracheal tube. In other words, it's absorbed through the lungs. You have to have lipophilic drugs in order for it to be absorbed through the endotracheal tube. Is NABLE is the mnemonic. Narcan, atropine, vasopressin, epinephrine, and lidocaine. Those are the drugs that can go down the ET tube. But you increase the dose 2.5 times the IV dose for no apparent reason. And I say for no apparent reason because there's no research ever that shows that any of these drugs are absorbed to any significant degree going into the lungs. It's just, it's what you do. Okay? Now, one thing about epinephrine, it comes in 2 other doses. Lidocaine that you inject, you're going to suture up a wound. Some lidocaine will have epinephrine mixed in with it as a vasoconstrictor. Like if you're trying to sew up a scalp, it's really nice to clamp down all those blood vessels so you can sew it up without all the bleeding. That epinephrine dose is 1 to 100,000.
Can you say that again?
The dose of epinephrine in lidocaine, it's 1% lidocaine with epinephrine at 1 to 100,000. You never use that. It'll be in the label is red and white. You never use that epinephrine containing lidocaine on fingers, toes, penises, or nose. Is anything that sticks out, you don't use epinephrine. Matter of fact, most hospitals now will not have that in the emergency room. They'll only have straight lidocaine. Straight lidocaine comes in a blue and white bottle. Always check your bottle before you inject like before you numb up a wound. Kind of off the beaten path here, but there's one other dose of epinephrine you should be aware of. You can get a bottle of epinephrine, it's diluted 1 to 1,000. If you're treating anaphylaxis, that's the bottle you use. 1 to 1,000. So if I'm going to treat an anaphylaxis in an adult with epinephrine, you remember last week, all the epinephrine was all in that talk. The dose in an adult is 0.3 milliliters. 0.3 milliliters of epinephrine at 1 to 1,000. So if I'm going to shoot epinephrine down the endotracheal tube, if I use the 1 to 10,000, if I do it 2.5 times the IV dose, that's 25 cc's I'm shooting down into the lungs, right? Plus follow it with a flush. You follow me? We'll get the bottle out of the cabinet, it's 1 to 1,000. That way you only have to shoot 2.5 cc's down the tube and follow it with a flush. Everybody follow me on that?
Did you say 0.3 or 3 for the analysis?
It's, I believe, 0.3. You might check me on that, it's either 0.3. I think it's 0.3, it's not very much.
How many cc's do you flush with?
What's that?
How many cc's do you flush with?
Oh, 10 cc's is fine.
Of just normal saline, right?
Yeah.
Yeah. So.
Yeah, normal saline, you can use lactate or ringers, but normal saline is the typical flush. Amiodarone is the next drug. The indications for amiodarone, VFib, pulsus V-TAC, Wolff Parkinson White. You can use it in stable ventricular tachycardia. They're all on that algorithm list. If you're in VFib or pulsus V-TAC, that algorithm, the initial bolus dose is 300 milligrams. You can rebolus it at 150 milligrams. If they have a pulse, the dose of amiodarone is 150 milligrams. So if you're in stable V-TAC and you have a pulse, then I'm going to give you 150 milligrams. And it's a slow push.
If you rebolus, do you have to wait a certain time?
Yeah, they recommend you wait 10 minutes, but 10 minutes in a code is a long freaking time. So I would, so epinephrine is the first thing I'd give. You do CPR, you shock them, you circulate it, you shock them. You do CPR for 2 minutes, no response, no pulse, give amiodarone, 300 milligrams. Go through the same sequence, give another dose of epinephrine, give another dose of epinephrine, maybe give them another dose of amiodarone.
Okay.
You got a dead person, so it's really not. The thing you don't do is you don't mix epinephrine with amiodarone in the same vial.
Okay.
They don't want you doing that anymore. The mechanism of action here, they have quite a few mechanisms of action. Basically, this is the one that's going to stabilize the myocardium for you. If you get somebody back, if you get an ROSC, then what you want to do is you want to prevent them from going back into VFib. Get the rate and pressure acceptable. Get the rate, the heart rate at least 60. Get the pressure at least 90 systolic, and then start an amiodarone drip. All drips are over time. The drip rate for amiodarone is 0.2 to 2 milligrams per minute. Start at 1 milligram per minute. If they're still having ectopy, you know what I mean by ectopy, PDCs, if they're still throwing a lot of PDCs, then increase the dose. If they become hypotensive, decrease the dose. When you start an amiodarone drip or you bolus with amiodarone, you're going to drop the blood pressure. So when I say get the rate and pressure good, if you need to get somebody's pressure up quickly, Give them a bolus of fluids, give them a liter of fluids, it's on that cheat sheet there. Give them 1 or 2 liters of fluid. If you need to get the rate up, give atropine, we'll talk about here in a second. Any questions about amiodarone? So on the algorithm here, VFib algorithm, let's say that I recognize VFib and I'm going to, yes, you're in VFib, right? So we're going to do 30 chest compressions and I'm going to shock you. First thing you're going to do is shock, right? So I administer the first shock, boom, and I convert you. Well, I don't want you to go back into VFib, so I want to get amiodarone on board. But I haven't given you any amiodarone. You have a pulse now. The dose of amiodarone with a pulse is 150 milligrams. I'll give you a slow bolus of that. Wait a couple of minutes, and then go ahead and start the drip. Well, you know, by the time you get the drip made up, it'll be time to get it, to start it. Okay? If I'm talking too fast, let me know. Because you're going to have to perform this in front of people on Friday. So if I'm losing you, let me know. Honey.
You said give 150 slow, right? Start the drip.
The rebolus, the initial bolus dose in VFib is 300 milligrams. All subsequent doses, for any other reason, it's 150 milligrams. Okay? So if you're over on the back side of this page here, let me get the other side. So if you're on the back side of this page right here, and you're over here in stable VTAC, and you give a bolus of amiodarone, and it doesn't work, you can rebolus it. If you're over here on the front page in the VFib algorithm, if you've given 300 milligrams and it didn't work, you can give another 150 milligrams. You can give a lot of amiodarone. Okay? All right.
I have a dumb question.
I doubt it. It's not,
So like, I know a bolus is like quick, it's not regulated, so how fast is that bolus given? Because when I think of, like, I know the epinephrine, you're shooting it fast just by yourself, but like 150 milligrams, is that in like a 50 mil bag, or like what's?
no, these things are going directly into the IV line. You're not putting it into the bag.
Okay.
They're going
So
directly
it's
into
like
the
a
IV.
bolus is the same as like the epis, like the epi?
Yeah, you're
Okay.
gonna-
Okay.
Well, when you're dealing with, you see where it says right there, the second bullet point under dose, 150 milligrams over 10 minutes?
Yeah,
I mentioned it's slow bolus.
okay,
This is slow because you're monitoring for the absence of ectopy and the presence of hypotension. If it starts, then you need to stop. But things like adenosine, that has a 20-second half-life. You gotta slam that in there.
yeah, right.
You gotta put it in within 2 seconds. Okay, so you're gonna learn how fast to give things, but where it's indicated, you need to know that. Atropine, antimuscarinic, parasympatholytic. So this is going to accelerate the heart rate. An amp of atropine is 1 milligram. So you give a half amp bumps. So but it's only going to last about 10, 20 minutes at the most. So if your heart rate's not caught up physiologically, I might have to give you another half an amp. So if you have a heart rate right now of 60, if I gave you a half an amp of atropine, I'd probably get it up to 120. It won't get it up over 150, but it'll jack it up, okay? And you'll feel a little jittery. The dose used to be 1 milligram, but they backed off on that. You can give it 6 times. Once you get to 0.04 milligrams per kilogram, 0.04, is that up there? No, 0.04 milligrams per kilogram, you block every muscarine receptor in that person's body. For a 70 kilogram person, 70 times 0.04 is 2.8. So that's why they say the max dose is 3 milligrams. In a 70 kilogram person, you have already exceeded 0.04 milligrams per kilogram, you blocked everything in their body. There's no need to give more. If you need more rate, then there are other ways to do it. By the way, atropine will increase rate, but not pressure.
Will that only block it for the couple minutes? You said it lasts like 10, 20 minutes. They're only blocked for that amount of time?
It's gonna last for a while, yeah. If you have to keep giving atropine, bumps of atropine, you need to move on to something else. For example, if you're out in Buffalo, and which is where Amy Hughes is today, setting up a rotation out there. If you're out in Buffalo and you come in third degree, you come in heart block or some problem that needs your bradycardic and your hypertension, you have hypertension. I can treat it by atropine and fluid boluses, or I can use a pressor. We'll talk about pressors in a minute. If you're going to be in a helicopter from Buffalo to Oklahoma City, I'm not going to keep giving you bumps of atropine. I'm going to put you on a pressor. But if after cardiac arrest, you come out of cardiac arrest in bradycardia, all I got to do is give you a little atropine to give your body the time to recover. You might only need 1 or 2 hits. Okay? Good question. Adenosine. Adenosine is the weird freaking drug. The only, so there's one, the indication for adenosine, there are really 2. One is stable supraventricular tachycardia. And the other is, the other time you use it is in stable ventricular tachycardia. So the thing about that is that well, why would you use it in stable ventricular tachycardia? Adenosine only works on supraventricular arrhythmias. Then why would you use it on VTAC? There's an animal out there. There's an arrhythmia, and I'll leave this, by the way, here too. There's an arrhythmia called this is atrial tachycardia with aberrancy. With aberrancy means there's a conduction delay in the AV node and it widens the QRS. You see the QRS is widened on the monitor here? Okay. QRS is widened. If you can't tell if that's VTAC or one of these aberrancy arrhythmias, give them adenosine. If you give them adenosine and it's one of these aberrancy arrhythmias, you may convert them. If it's true VTAC, it won't work, but it won't hurt them. Okay? So it's number 16, function 16 on this thing when you're out playing around with different rhythms here. Function 16. All right, so this right here would be ventricular tachycardia, wide complex ventricular tachycardia, right there. Okay? That's what that looks like.
So adenosine won't?
Adenosine won't work if it's VTAC, but it won't hurt them. So you're using adenosine as a diagnostic tool. Did I say that up there?
Mm-hmm.
Yeah, there you go. Diagnostic tool with stable VTAC. If it doesn't work, then it's stable VTAC. If it did work, then it was one of those supraventricular plus aberrancy. Now, I said the half-life is really short on this thing. You got to slam this stuff. The dose is 6, 12, and 12 milligrams. Follow it with a flush. And if it's going to work, there's a thing called a sinus pause. So I'm going to speed the thing up here. We got a rate now of 200 beats a minute here. It's a narrow complex right here, okay? So if adenosine's going to work, it's like this. Are you ready? Watch the monitor. You push it, and you'll see a sinus pause before it kicks back in with a regular sinus rhythm. That sinus pause is true asystole. For a split second, from 2 to 15 seconds, the cardiac output is 0. So they feel like they're going to die. And if they've ever had adenosine, they don't want it again. Okay? Wolff Parkinson White looks exactly like SVT. But you do not give adenosine in Wolff Parkinson White. Matter of fact, the only thing, according to your algorithm, you can give is amiodarone or cardioverter. Right. Any questions?
Will you still have that if you have VTAC?
If you have VTAC,
Like if it
you will
doesn't
have a
work,
sinus
you still
pulse.
have that.
I'm sorry, if you have VTAC, it won't work.
So you won't have a sinus
It
pulse?
won't have anything,
Okay.
it won't work. If you have one of the atrial tachycardias with adenosine, yes, you will have a sinus pulse. And they feel horrible. Because all of a sudden, I mean, if you can imagine your cardiac output goes to 0 for 5 seconds, you don't feel well. Cardizem is a drug you can use instead of adenosine. It comes in an amp. 10 milligrams is the adult dose. It's a slow IV push over about 2 minutes. It's a calcium channel blocker, works great at converting SVT. Although you cannot give it either for Wolff Parkinson White. Mag sulfate is used, a couple of indications for it. One of them is in torsades. If you'll notice on the back page right here, this block right here, torsades is irregular or polymorphic ventricular tachycardia is what it is. You treat it like VFib. If they're stable, if they're conscious, they're stable enough, they're hemodynamically stable enough, you can try mag sulfate, 1 to 2 grams over a considerable period, what seems like forever. It might convert it. If it doesn't, then you have to defibrillate. Defibrillate. Okay. It's also used in post-MI, especially in people who have been determined during their MI admission to be hypomagnesemic. Nitroglycerin is a drug vasodilator to use in coronary syndrome. Dilates coronary arteries, dilates all arteries, basically. You're going to get a hell of a headache with it. The dose of nitroglycerin is 0.4 milligrams. You can give it every 5 minutes if they're hemodynamically stable. If their blood pressure is not 90 and you give nitroglycerin, which is going to dilate arteries, you're going to drop their blood pressure, you can't give it. What you have to do is you get their blood pressure up by giving them a bolus of fluids, and then you can give nitroglycerin. You give it 3 times, and then you need to do something else. Now, one of the things you can do is nitroglycerin comes as a drip. It comes as a paste, where you have a little piece of paper that has inch markers on it, has 2-inch markers on it, and nitroglycerin paste comes in like a toothpaste tube. You just squeeze it out on the piece of paper and stick it to their body. I mean, just put it on, smear it, and just slap it on their body. And it goes transdermal. You do it over the heart. It goes transdermal, works great. I prefer to do that over a nitro drip. If you do a nitro drip, you always run into risk of hypotension. With a nitro paste, all you got to do is pull the paste off if they become hypertensive. Yeah, nitro paste. Nitroglycerin pills come in a little bottle. They're tiny, tiny little pills. They are very sensitive to degradation with light. So if anybody says that they take nitro, find out how old it is. If it's more than a few months old, it's probably not any good. Nitro also comes as a spray. When they come in the ER, if they've got a pressure over 90, just say open your mouth, touch your tongue to the top of your mouth like that, and you just squirt it like chloroseptic spray underneath the tongue, and it gets absorbed immediately. It does, as I say, produce a raging headache, especially in people who are naive to nitro. If they've never had nitro, it's going to give them a horrible headache for a while. Morphine, two indications, MI and for pulmonary edema. Morphine, the dose down there says 2 to 5 milligrams titrated to desired analgesic effect, or whatever the bottom thing is. People, or analgesia or anxiety. People who are having an MI, as I think I've mentioned to you before, they have a sense that they're dying. It's horrible. They're diaphoretic. They're in pain, crushing pain, and they know they're going to die right there on the spot. And so if you hit them with morphine, it not only acts on the vessels, the analgesia and the anti-anxiety will go a long way to helping you in the situation. Now, it's going to drop the blood pressure. So if they're hypotensive, remember, you got to get their blood pressure up over 90 before you start giving any morphine. 2 milligrams of morphine, I would start with that. If you didn't get some good pain relief along with the morphine and the nitro, because the nitro is going to give you pain relief too, then after about 5 minutes, give them a couple more milligrams of morphine. Morphine is slow to catch up, so you don't want to wind up giving somebody 10 milligrams of morphine and then it all of a sudden hits. The next thing you know, they're not breathing on you. So go slow with morphine. Great stuff. Dopamine and dobutamine are both pressors. So I put dobutamine in there. The indications and the use of these two are the same. The only difference between the two is that dobutamine does not increase myocardial oxygen demand. Dopamine does, but to a much lesser extent than epinephrine. If you need a pressor, if you need to get that guy from Buffalo to Oklahoma City, put him on a dopamine drip. 2 to 10 micrograms per kilogram per minute. I would start with 7.5 micrograms per kilogram per minute. You can titrate it up or down based on blood pressure and heart rate. It's both a chronotrope and an inotrope, so it's going to give you rate and pressure. Any questions about that? This is illustrating something I want to talk about here. So when you intubate someone, I've got ET tubes. This is an endotracheal tube right here. You see the number on it? The number is the inside diameter in millimeters. An adult tube is somewhere between an 8, 8.5, and 9. That's, they go all the way down to T90 for infants. So when you're going to intubate somebody, you get an ET tube. These things are sterile, but understand that the process of intubation when you're dealing with cardiac arrest is anything but sterile because the mouth is going to be full of vomit. So when you get an ET tube down, you want to confirm that they don't go down there. You want to confirm placement. And by confirming placement, what you do is you take your stethoscope. So you just intubated this person, and you listen in 5 areas. The 2 anterior lung fields, the 2 lateral lung fields, and over the epigastrium. If you intubated the esophagus, you're going to hear gurgling. If you put it in too far and it goes down into the right main bronchus, you'll hear breath sounds on the right, but not on the left. Pull it back an inch or 2. okay? The other thing to help you confirm placement is a qualitative measurement. This thing right here is called a CO2 detector, carbon dioxide detector. So once we've got the tube in, we're going to put the CO2 detector on the tube, and we're going to take our mask off. Now this thing right here is hooked up to 100% oxygen on the wall, right? So I'm blowing in 100% oxygen. I hook this onto that. So when I compress the bag, so they're doing continuous chest compressions, I'm doing continuous bagging, because this is definitive airway, right? So every 6 to 8 seconds, I just squeeze the bag. After about 5 or 6 breaths, so when I push this air in, they're exhaling, right, from the chest compressions. If there's CO2, it will turn that filter paper from purple to yellow. Here's the CO2 detector I'm going to take right out of the bag. It's purple. Look at this. Turned it yellow right there, the first breath. Okay? So that will help you confirm placement. And they're little bitty ones. They're all the same. Okay? After about 5 or 6 breaths, the filter paper should turn purple to yellow. If you're in the right main bronchus and you're getting some CO2 back, but not the full complement, it'll be this intermediate tan color. So this is what's going to happen to you. You're going to get your first tube in. You're going to get your CO2 detector. You're going to squeeze this bag 5 times. You're going to look down at the piece of paper and say, crap, what color is it supposed to be? The dumbass little heart association mnemonic is purple problem, tan think, yellow yes. Tan think about why it's not yellow. So purple problem, yellow yes. That's the thing you need to keep in mind. Okay? This is qualitative. It doesn't measure anything. There's another thing called waveform capnography. If you've been reading your book, looking at the papers, you've seen waveform capnography. There's a pressure sensor that goes on the ET tube between it and the ventilator. When you breathe out, the pressure of CO2 goes up. Right there is the end-tidal CO2. It's the PET CO2, positive pressure, the partial pressure. PET CO2, you've seen it on that thing, right? That should be normally, in you and I, 35 to 40 millimeters of mercury. You see that right there? It says 50. So that right there is about 35 to 40 millimeters of mercury. That's a quantitative confirmation that you're in the tube, that you're in the trachea. If you're in the esophagus, it's going to be 0. Now the other thing about this is during cardiac arrest, when you're doing effective chest compressions, when you're doing everything right, you're only providing about 25% of the cardiac output. Which means you're only going to get about 25% of that. Which means 10 millimeters of mercury. You need to be able to keep the capnography at 10 millimeters of mercury. If it falls below 10 millimeters of mercury, that's telling you you need to improve your chest compressions. Okay? You can't get it back to normal. You don't have enough cardiac output for the gas exchange to occur. All right, let me ask you a question. I just intubated this person. I know it's in the trachea because I saw it go right through the vocal folds. I listened into the 2 lung fills. Perfect. Nothing over the epigastrium. That thing stays purple, and that thing stays at 0. Why? What? Saddle embolism. Have we talked about this before? Yeah, okay. You're not having any circulation through the lungs. What's this on the monitor, by the way? That's
VFib.
VFib. What's the thing about, what's wrong about this picture? I said you can't get that at 40 millimeters of mercury in VFib.
Hyperventilate.
For one thing right here, if you look at that, that's just VFib. The heart's just sitting there. There is no circulation through the heart. When you do chest compressions like this, the electrical activity of you doing chest compressions looks like spikes. So nobody's doing chest compressions. You can't have a capnography at 40 millimeters of mercury if nobody's doing chest compressions and your ass is in VFib. It's not possible. This is just made up. Okay? All right. Any questions about that? All right, so here are some examples of what happens in capnography. If you are in the trachea and you've got blood flow through the lungs, and that capnograph falls below, remember, it's not a ventilator setting. It's not turn up the ventilator. It's improved chest compression. Because chest compression drives cardiac output. It's cardiac output that drives gas exchange, not the ventilator setting. Okay. All right, so I want you to take a break, and then we'll come back and we'll start doing some things.